pleased to introduce our legislative panel this morning. As Dave mentioned, we've got a great crew from the legislature that are here to speak to us. I do have a few questions for them. We'll probably just leave it to some opening remarks, and it may carry through the entire time that we're allowed, but if not, I've got a couple things that I could ask them for their feedback on as well. So all the presenters have indicated that this presentation will not include a discussion of any commercial products or services, and will not include any discussion of off-label and or investigational uses of any product or services, and will not include any trade names. First of all, Senator Judy Lee graduated from the University of North Dakota with a medical technology degree and worked 10 years in labs. A career change came with a real estate license, resulting in 35 years in the business, most of that time as a broker. While an active broker, she ran for the North Dakota Senate and was elected first in 1994. Senator Lee was assigned to the Human Services Committee and has served there ever since as chair since 2001. A variety of community boards and activities, as well as those of her family, have always been part of her life. Next, Senator Tim Mathern has served continuously in the North Dakota Senate since 1986. He serves on the Senate Appropriations Committee and on the subcommittees of Health and Human Service agencies. He has degrees in social work and public administration and is employed at Prairie St. John's in Fargo. He serves on the Advisory Council of the University of North Dakota School of Medicine and Health Sciences. Next, Robin Weisz is a member of North Dakota House of Representatives representing District 14, a very rural district for which he has served since 1997. He's a farmer and businessman, is married to Lori with 2 sons. He served as the chair of the Transportation Committee from 2001 through 2005, and became chair of the Human Services Committee in 2007, in which he's currently chairing. He's been very involved in the rural healthcare issue since being elected, received the EMS Legislator of the Year award twice, and has worked in the legislature to make sure our rural populations receive accessible and quality health care. And finally, Gretchen Dobervich. Gretchen serves as a public health policy manager for the American Indian Public Health Resource Center under the Masters of Public Health Programs of North Dakota State University. Gretchen received her Bachelor's of Social Work from Minot State and is a licensed social worker in the state of North Dakota. In 2016, Gretchen was appointed to the North Dakota House of Representatives. She serves on the Human Services and Agricultural Standing Committees, Healthcare and Natural Resources Interim Committees, Employment Procedures Committee. Gretchen serves on the School of Medicine and Health Sciences Advisory Council, YMCA of Cass and Clay County's Child Care Committee, and the Home Board of Directors, and is past chair of the North Dakota Rural Health Association. She is a member of the Dakota chapter, Daughters of the American Revolution, American Legion Auxiliary Post 151, North Dakota Rural Health Association, American Public Health Association, the North Dakota Public Association, and the North Dakota Farmers Union. Welcome, legislators. It's great to have you here. We look forward to hearing from you. And I'll turn the floor over to you for some opening comments and some discussion. Thanks for being here. Thanks for taking some time out and sharing with us today.
This is Judy Lee. I don't know if you have an order in which you'd like us to go, but what I might suggest is that we've made a few notes only to make sure we didn't miss anything based on time. So each of us has some things we'd like to cover, but if Senator Mathern is unable to get on, we know what he was going to talk about, and I want to make sure that we get that in before the end. So please, we'll keep a little time for that if we might. I would, if it's all right with you, Pete, I would ask perhaps if Representative Weisz would like to start, and then if Representative Dobervich would like to follow, because I have kind of the mop-up list in my little group that I'm looking at, and I'll cover stuff that other people aren't doing. So would that be okay?
Okay, thanks, Judy. You can hear me okay?
Mm-hmm.
Okay. So yeah, we had a very busy legislative session. Human Services was probably one of the busiest committees, obviously with COVID, the pandemic, and all the issues with vaccines and masks. And I know Representative Dobervich is going to talk about some of those issues more, but couple things just in the broad that I thought I would cover is one, of course, we did pass legislation dealing with the governor's emergency powers and the state health officer's emergency authorizations. Just for a little update, and basically all we really did was make sure that if the legislature felt the need, it would be the governor would have to call us in to work with them over some of these issues, only if the legislature felt there was a reason, whether it was maybe for funding sources or changing some of the laws that needed to be done to make sure, say, the emergency is handled properly. And so I think that was a good compromise and a good step we did. It doesn't limit the governor's authority to deal with an emergency, doesn't put time limits on him. The only other thing was the state health officer would not be able to declare, say, a statewide health emergency unless the governor also had declared a statewide emergency. The other two issues I would like to talk about, I guess, is that we did some major changes, and the big one was merging of the health department in with the Department of Human Services. Certainly is a big change. It's going to take time to do, but I think there's going to be some very positive outcomes to this. From my perspective, at least, having been on human services for 6 years, whatever it's been a lot of frustration sometimes where health department, for example, I'll use long-term care. Health department is in charge of licensing long-term care. Department of Human Services is in charge of administering, you might say, the services in long-term care. Sometimes they don't always agree or talk to each other. And there's just, a lot of issues that would arise of one hand know what the other hand was doing. That's just one example of a lot of things. Also, I think local public health is extremely important, and I think better cooperation with local public health, working with, say, our local social services agencies is important. We need to utilize all the tools we have to be, one, deliver the services to the client, because that's really should be everything that we're about here on the state government, is delivering the most efficient and best services to those that need it out there. So I think that move of merging is going to take time. The bill that was passed is very flexible. It gives the departments and the executive branch plenty of time to work out on how this merger will take place, how to combine things and maybe leave some things standalone. So I think that's an important move that we made, and I really hope that it's going to offer better health care, particularly in rural areas, frankly, because generally they're the ones that end up on the short end of the stick. The other thing that I would cover is that we did combine all of early child care programs in with the Department of Human Services. And while not everything might be considered healthcare related, the reality is a lot of them, between mental health and physical health of those in the 0 to 5 range, is critically important. And again, the same problem we'd have when somebody would show up in committee and we'd ask questions and they'd say, well, I don't know, that's under DPI, or I don't know, that's under the health department, or I don't know, Commerce has that. And so now we're moving all the funding and all the programs into DHS. There'll certainly be collaboration with DPI and others, but I think it's an important step to ensure, again, that we're getting the best use of our funds, using our resources properly and providing the best services for those children. As everybody knows, that 0 to 5 is the most critical time. And so that's, the things that I was elected to talk about. I guess the only other thing I'll mention that we didn't think of earlier was the House did pass legislation dealing with any willing provider. And then, went over to the Senate, a tremendous amount of discussion and debate. And I think, and it was turned into a study, which we will be looking at in the Healthcare Committee this interim. And I think it's very important too, because there's an issue again of some of these narrow networks Somebody's used to going to a certain provider. Now they can't unless they want to pay extra. It's a complicated issue. I think it certainly needs to be looked at. So I'm hoping that as we study it, we might be able to come up with solutions that will still allow the advantages of narrow networks, but also make sure that our independent providers are able to provide services to their clients both today and in the future. So with that, I guess, turn it over to Gretchen. So thank you.
Gretchen, it's all yours.
All right. Thank you, Chairman Weisz. So I'm going to talk a little bit about some of the vaccination and mask related bills that there was a large quantity of in both the Senate and the House sides related to COVID. And we had bills relating to information, being informed and providing consent before vaccination, bills related to surveilling water for COVID infection, looking at masks, a lot of bills and conversations around vaccine passports, and in the end, the two bills that reigned were House Bill 1465, which was signed into law, that prohibits state government entities from requiring documentation of vaccination or infection status to access state property, state funds, or state services. Private businesses located in North Dakota may not require patrons or customers to certify they've been vaccinated or their recovery status to enter or receive services. Under this law, healthcare providers, including long-term care services, are excluded. And there is a caveat in this section that it doesn't apply during the public health disasters or emergency declarations. So if there is an active public health disaster or emergency declaration, this would not apply. And the other one was the House and Senate overrode the governor's veto of House Bill 1323. And so effectively August 1st, the executive branch, including the governor and state health officer, are prohibited from issuing statewide mask mandates. And so all of the bills related to COVID vaccination and vaccine passports and mask mandates, those were the two that made it through. One of the other bills that I want to talk about is a study that has been selected that I admit I have some bias. I was the prime sponsor on it. But I think it's really exciting, particularly for rural health, in that there's going to be a study of the end user experience and outcomes related to telehealth. And I'm really excited about this because we have made a lot of investments in the state in telehealth. And we rely on telehealth in a lot of our rural areas. And we've done evaluation on investments and the impact in the medical community, but we've never looked at the end user outcomes yet. And so I believe that this study is going to bring us full circle, and I'm excited to see what kind of policy to strengthen telehealth comes out of it as part of that process. And then the last bill that I'll be talking about is House Bill 1407, which is of importance to tribal, rural, and public health. It increases the percentage of the 100% tribal federal medical assistance percentage that the state budget saves, with the federal government paying that 100% when a Medicaid enrolled member of a federally recognized tribe utilizes health care outside of tribal care or IHS. And initially, the percentage was 70% being reinvested into tribal communities and 30% staying with the state. That percentage has been moved up to 80% being directly reinvested in tribal communities. And it needs to be used for public health services. So the 10 essentials of public health. And there's also some wordage in there about utilization for capital construction costs. Construction can be part of how the funds are used. 50% for the first 3 years and then 35% after that. And this is a real opportunity for direct investment by the Departments of Health and Human Services in North Dakota into tribal health, where we have some of the worst health outcomes in North Dakota. So it'll be exciting to see the impact that has on reducing health inequity. And with that, I'll turn it over to Senator Lee.
Representative Dobervich, did you want to mention the Cognito program too?
I'm sorry, would you repeat that, Senator Lee?
Would you like to just give a few words about the suicide program, the Cognito program? That was your bill, I think.
Oh, it wasn't my bill. I was one of the co-signers on it.
Okay.
But the Cognito bill is aimed at increasing community and education providers' knowledge of the signs of suicide and enhancing services for people across the state.
Thanks.
Gretchen,
Yes.
there is a question in the chat box, and I believe we have Senator Mathern on the phone. So if you want to answer the question is, are primary care clinics excluded from that as well? I think it's that first bill that you were talking about, proof of vaccination and mask and things like that. So there's a question, and I think we'll be able to hear from Senator Mathern. He's on the phone.
Okay. Yes, my understanding is that primary care clinics would be excluded if there is an active public health disaster or emergency declaration by the governor.
Senator Mathern, are you there?
This is Tim.
There we go.
Okay, I serve on the Appropriations Committee of the North Dakota Senate, and while the House Bill 1012 was in the Senate, we added Section 5, which is in regards to statewide acute psychiatric and residential care needs. That section was added with the conference committee work, and it essentially asks legislators to study the issue of acute psychiatric hospitalization and the state hospital. It sets up a committee of 8 legislators to study this issue and come to a recommendation to the next session of the legislature. The committee is to get input from the stakeholders, including private hospitals, Department of Human Services, and mental health advocates. The study is to look at how many beds are actually needed for acute psychiatric hospitalization and to determine where those beds should be located throughout the state. And included in this study is the consideration that the treatment would be in at least 4 cities in the state, and that the committee would give some recommendation as to how that would be done, and the state hospital would be focused on forensic psychiatric evaluation and treatment. So essentially the process would be the state hospital would care for those people that are criminally charged, but would not be providing care for other citizens of the state, and those citizens would get that acute care in other hospitals. The concept behind that is, we used to have places for persons who had leprosy or tuberculosis or polio that were outside of the private system. And now modern psychiatric care would suggest psychiatric care should be in the private system also. Just like we don't have hospitals for those conditions, and we don't have state hospitals for breast cancer or prostate cancer. So let's do the same for mental illness and substance use addiction. The committee would look at statewide and national trends in terms of psychiatric beds. We'll look at considering contracts with private hospitals, kind of with the assumption that maybe the bigger private hospitals in the state could provide all of this care if they were properly reimbursed and properly organized. And then the Department of Human Services would be required to give this committee a description of all the other services that are available that would keep people out of psychiatric care beds and provide follow-up services. The study would also require the Department of Human Services to prepare and submit a Medicaid waiver application so that there would be federal funding available for patients between 21 and 64, which are now excluded from Medicaid benefits based on the federal Medicaid law. The recommendations of the legislature of the 8-member committee must be done by October 1st, and the legislature is given $500,000 to use for this study in terms of getting consultants to provide data. So essentially that's the psychiatric bed study that will be starting in July, this July, and finishing in October of 2022. I really encourage all of you folks in healthcare to take part in this study and to help figure out how persons with mental illness can get treatment in the communities just like they can in other forms of healthcare. Thank you.
This is Judy Lee again. I'm going to follow up on what Senator Mathern just talked about, because something that holds hands with the topic he just discussed is a substance use disorder voucher. And that was implemented 4 years ago, but it took a while to get everything set up. But what it does, I'm going to give you an example because I like to put faces on stuff. If I lived in Valley City and I needed mental health care, behavioral health care. Behavioral obviously includes both mental and behavioral issues. If I live in Valley City, my only options prior to the SUD voucher, if I didn't have private insurance, if I'm on Medicaid, would be to drive to Jamestown or to Fargo for appointments at one of the regional human service centers, who are the safety net, as you all know, for services in all 8 regions of the state. But maybe I don't have the money for gas. Maybe I don't have a reliable car. Maybe I can't get off work. Maybe I don't have a job. Maybe I don't have childcare. So maybe I just don't go to those appointments. However, with the SUD voucher, substance use disorder voucher, as an eligible person who is qualified for Medicaid services, I can now contact somebody in Valley City who is a private provider who is registered as an accepted provider by Medicaid, who is willing to accept Medicaid reimbursement. And I can take that voucher to the Valley City provider and I can get services close to home. That also means it will include my family, so that maybe together we can work even more effectively in assuring that my addiction or mental health issues might be addressed more successfully. We had no idea, I hate to say dartboard, but that's kind of it. In the previous session, $8 million were allocated for this as it was getting going, and it took off unbelievably. I mean, it's one thing, it's really bad that we have this much of a need, and the other thing, it's really good that we had implemented this program. The downside of it was that in August of last year, the funding was going to run out, and so what they did was figure out other ways to pull money from roll-up services and so forth, dollars that weren't being used in other programs, in order to keep the currently enrolled people still in care, because that's important, and also to pay for methadone, because now the feds will allow methadone reimbursement from Medicaid, but prior to that, that was general fund money too for our opioid addicted people who need it every day. So anyhow, now what has happened is there's now a $17 million appropriation. Something like 4,200 people have been served through this program, which is quite remarkable. I looked at the number twice, hoping that it was accurate, and I believe that it is. So part of the challenge for us there is that the federal regulations say that we, in the interest of not having institutionalized care, as Senator Mathern had mentioned earlier, there's a limit of 16 beds on a treatment facility. Unfortunately, from a cash flow perspective, it's very hard for a private, not-for-profit even, to be able to make it with 16 beds. And so that has been a limiting factor. And we need also to have facilities that are out west. So with that $8 million that was provided, the majority of the money was used by larger facilities because the SUD voucher is all general funds. This is getting into the weeds, but you need to get this. All general funds. And if we can get Medicaid reimbursement for some of those services, then it's half general funds, half state taxpayer money. So we want to figure out a way to make sure appropriate services can be provided out west. And we need to look at how we are limited by the federal regulation called the IMD limitation, which is opposing large institutional settings. And it came from a time when it was, the whole philosophy was different. So anyway, that ties in, and we're very happy with that SUD voucher and the fact that the legislature approved significant additional funding. You might also be interested to know that out of the 49 appropriations bills that passed, 48 of them came out of the conference committees unanimously, out of the appropriations committees, I should say. That shows you that there's a lot of bipartisan collaboration. No matter what you see on blogs, social media, or in the news, there is a lot of collaboration among people working hard to try to work this out. And for 48 out of 49 budgets to come out of committee unanimously tells us that there was a little bit of compromise on more than one side, and it came out with everybody feeling it was the preferable solution. Quickly, a couple others, and somebody's got to, I don't have a clock in front of me. So Children's Cabinet and the Commission on Juvenile Justice are a couple of important things. That was initiated 2 years ago because this, again, back to talking about how it affects a person. We don't want children, youth who have been judged as unruly, deprived, or delinquent to have to go into the juvenile justice system in order to get behavioral health treatment. We also don't want the mom who may have substance use issues but is not selling or criminally involved like that, not to have to be put in jail in order to get care. She should not have to declare herself as an addict and get into the criminal justice system. So the early childhood programs, not early childhood programs, but the Children's Cabinet is looking and will continue to be in place to watch over those programs which are providing family wraparound services to those kids. And in the last interim, Representative Clemene was the chair of the committee which rewrote the entire juvenile justice code. And a significant number of youth, over several hundred, are now being moved into the human services service area under DHS. Now, if they were selling or stealing or doing something else that is criminal, they will remain in the juvenile justice system. But the vast majority of them are going to be moved into family and individual services in DHS. And hopefully that will not set them up as someone with criminal records and be able to get them into a good path towards adulthood there too. Long-term care visitation, we all heard a lot about that during the whole time of COVID. A bill was passed which enables a resident of a long-term care, either skilled care or basic care, to name an essential caregiver who will be permitted to come in wearing, using PPE if necessary, following proper precautions depending on what the emergency is, and will always be able to visit that person in the senior facility. So that's really helpful. We talked a lot about prescription drug costs. There isn't a lot that we can do in the state, but we're doing some looking at perhaps purchasing groups with other states that might enable some reductions in the costs to us. Community paramedics are a new profession, another level of emergency service providers that are going to be important in all over, not only in the rural areas, but certainly it will help us in the rural areas as well, to make sure we're providing good care. And community health workers also are an extender that post-surgery and also chronic disease management are a couple of things that come to mind there. There also will be a study of the services being provided to individuals with developmental disabilities, and developmental also includes intellectual disabilities. So we're not separating them. One is a part of the other in the same way as both addiction and mental health are part of behavioral health. I think that's it for what I have to add. And so got a couple other things if there's time later, but leave it open to questions and other comments from the other participants at this point.
There's a couple questions in the chat box, and I'll try to read them. I won't be able to interpret them. If need be, somebody may need to join in. So there's a question from Karen Ahrens. Representatives, how can public health communicate suggested items and investments for the American Rescue Act funds that are coming to the state? Anyone can answer.
Senator Mathern, as an appropriator, you might be a good one to talk about that. Do you have some thoughts to offer?
Essentially, each cabinet department will be providing data to the Office of Management and Budget, which is sort of the governor's arm of the budget and management system of the state. So I would suggest people in public health direct their recommendations to the new state health officer, Dr. Wiebe, and he would be the person then to bring that material to the Office of Management and Budget, which to my hope will be then brought to the entire legislature for allocation of those funds in a special session of the legislature. If that does not happen, it would go to the budget section, and then the budget section could make those determinations in the coming year. And to essentially, the funds can be used all the way through 2004.
24.
There hasn't been an emergency to get those requests in, but I think the sooner you can do it, the better, and do it directly through the Department of Health, Dr. Wiebe.
There's a question, I think, for Representative Weisz, Barbara Friedenland. Please, if this wasn't your comment, whoever did, please elaborate on the comment referencing local public health working with social services. Are you suggesting that the local public health units are expected to relinquish autonomy and follow the zone concept as has been done with local social services?
I guess I'll take that because I did make the comment. No, what I think is that oftentimes there's overlap. You're dealing with the same clients. And so certainly I'm not implying that one is taken over by the other, but you know, our local public health is very important, and it just seems like social services are dealing many times with the same clients, similar issues. There ought to be better collaboration. I think that will be one of the results of the merger, to allow that better collaboration between the two. So certainly I think local public health will continue to have its autonomy. That's the way we wanted it. We've always set it up that way. I know there's been suggestions in the past that local public health should just become part of the state health department. Legislature has never supported that. It's always resisted that, and I don't see that changing any. So I hope my comments maybe weren't misconstrued. I just think when we're providing boots on the ground, we're providing services to the same clients, it makes sense that each one knows what the other one's doing and that they work together versus maybe working in separate silos.
If I could make a comment about that as well, we had some really ridiculous examples of that during the beginning of the COVID pandemic, where the governor's whatever they called it, unified command, was setting things up that should be done, and the health department wasn't aware of it, and the local public health units weren't aware of it, and some of my friends in public health and I had lots of chats during that time. So communication is a big deal. I agree with Representative Weisz about the autonomy of public health units. And I think there needs to be some way perhaps for the local PHU directors to maybe have a loosely arranged, I don't want to, have to go to a whole bunch of meetings all the time, but to think about what the needs are in your areas. The reason we want you to be autonomous is that the needs are different in every unit. And I'll bring those concerns forward. I think it's important to know when we're talking about health, the state health department office is one thing, and the local public health units are another thing. So we don't, legislators who are familiar with this don't put them all in the same basket. But we all should be holding hands. We maybe aren't engaged and married yet, but let's see if we can't figure out a way to work together well.
All right, Tim, jump in.
Okay, Tim Mathern commenting. I just want to clarify that this bringing together of the departments is, while acted on by the legislature, is really an executive activity, and there is time for input here into the process, and there will be some study done and some consultants used to try to make this work. And I think there is some latitude to change the situation in the process. So I would just encourage everyone to make sure that they use processes to give input. They use processes in their departments to give great suggestions and to give warnings about things that maybe are not such a good idea. So I encourage everybody to use those processes, whether you're in the Department of Human Services or in the Department of Health. I wanted to bring up another item, and that is health strategies. The legislature was asked by the governor to put $3 million into a development wherein the end product is North Dakota citizens being the healthiest of all states' citizens. And the legislature, in the end, approved $1.5 million and asked for the private sector to put in $1.5 million to carry out this program. So that is another vehicle where healthcare providers could get involved in setting healthcare policy going forward. I think we can raise that $1.5 million to have a robust program at the $3 million level. And that program includes developing processes for communicating with one another, developing ways to set goals that we can work together on, and developing ways to educate more folks in public health at higher levels than we presently do. So that health strategies initiative should be on everybody's radar, and I hope we can all work together on that during the next couple of years. Thank you.
I'd like to comment a little here. I see there was a question on the merger too, and I neglected to say that the state health officer will still be a cabinet level position. The health officer will still be appointed by the governor. And that was one of the reasons for the merger, was to let the health officer focus on health and public health instead of the administrative role of running the agency. And so part of the changes we made requires now the state health officer to be a physician and to have public health experience. So I think that's important to note. And as Senator Mathern stated, this merger may go on for years. The legislation is very open-ended. It doesn't put any deadlines or requirements. It does leave it up to the executive branch and the departments to figure out how this should take place, where the efficiencies are, where they can gain by combining, where they need to leave things separate. So all of that is very open. So as Senator Mathern said, plenty of time for input from whether it's local public health or anybody else to how this merger should take place.
I'm trying to jump back and forth between chat box and Q&A. There's questions popping up on both. So there is one on Senate Bill 2179. It seems like it's a little bit of a question and comment in this at the same time. The question is, if you could elaborate on Senate Bill 2179, the study of telehealth parity and what happened with the bill, and does the lack of support for telehealth parity create an advantage for out-of-state providers without facility cost overhead, while providing a large disincentive for in-state behavioral health and healthcare providers to offer those services to clients in rural areas? So we'll just tee that up for anyone that would like to jump in.
Well, this is Judy Lee, and I'll give it a shot. We had a ton of time spent in our Human Services Committee in the Senate talking about this bill because it looks like such an easy thing. It's sort of a short bill, actually, and yet the devil is in the details. So there is actually, as a part of the interim study work of our interim, we're going to be looking at telehealth and how to resolve this. We become very dependent on it during this COVID pandemic, which actually demonstrates that it can be used in so many areas that one never even considered using telehealth before. So we know it's important, and we know that there's work required for the providers. The interesting thing is that in some areas, behavioral health care is more easily accepted by individuals in rural areas, because let's say that I live in a very small community, but there's a mental health provider there, and I'm zipping into the office. I might not want everybody to know I'm going in for mental health counseling. Whereas I can sit in my kitchen and visit with that provider, confidentially, and nobody sees where I'm going. We shouldn't have that stigma. I get that part, but let's just recognize that for some folks that's an issue. So we will be looking at how we can make that work. The other thing is that the insurers are looking at engaging. They're discussing this right now, and so it's certainly possible that they will be able to come forward with programs that will be initiated through their particular business plans, which would actually be better than the legislature having some kind of one-size-fits-all deal too. So watch what's happening, provide input again, and I'm sure it's going to come up in 2023 because it is really an important issue, and we don't want to jeopardize anybody's health, and we want to make sure we're able to get these services provided throughout the state, not just where the providers might live.
Question from Shannon Bacon: Where could we continue to hear updates on the health strategy initiatives as it moves forward?
Address that, Ann. Amy.
Yep,
This
go
is
ahead.
Tim Mathern. The health strategies group, which included legislators and healthcare professionals, and Josh Wynn of the School of Medicine and Health Sciences, met a number of times before the legislative session, but has not been reconstituted since the legislative session has concluded. I suspect it will have a meeting within the next month. In fact, I will ask that it be held. I did have a meeting yesterday with Dr. Wiebe, the new state health officer, and I would suggest we put that fine gentleman to the test. He is well qualified. He has an MD degree. He has a public health degree, and he has a master's in business administration. And I think we should look to him for his leadership of getting that health strategies session activated, which includes raising $1.5 million to put in with the state money. And there might be some other leaders there, but I would suggest we try to focus around our new state health officer, and I will specifically ask him in light of this question, that people in the healthcare community get a memo soon about when it meets and who will be on the committee. Thank you.
Another question, thinking of social determinants of, please discuss HB 1257 to rectify unequal pay for women and men.
I can take this one. When I look up House Bill 1257, it's actually a seatbelt bill. So I don't know if anybody else on the panel knows which bill specifically addressed unequal pay. The bill number's not coming up in my head. So I don't know if someone's able to answer that or not.
State doesn't discriminate between women and men. No public place does. The salary that's determined and benefits is for the position. And so if there's an issue aside from that, I mean, you can look at that, but the only thing that we can really regulate as far as actual salaries go, aside from the minimum wage, which we have, and everybody's making almost twice as much as what that is. We do not, in visiting with employers, they're paying whatever the job deserves. They're not looking at whether it's men or women. So I think if you got a situation of which we're unaware that we need to know about, you might send an email to any one of us or all of us and let us know about it.
Question that I'd written down from earlier, interim studies, anything that the public health or rural health people will want to keep their eye on or have on their radar as we look forward to those interim studies taking place.
Robin, you're on legislative management. You want to talk about that?
Now you're asking me to remember all the studies we approved. There are many dealing with healthcare. I mean, there will be both a Human Service Committee interim and a healthcare interim committee. I'll be chairing the healthcare, and I believe Judy's chairing the Human Service Committee. This upcoming interim, we're going to be looking at drug prices. We're going to look at medication utilization. Any willing provider, which I mentioned earlier, will be looked at. I think Gretchen mentioned a study that we're going to look at. I'm drawing a little blank on some of them, but we will be busy. I mean, there's going to be a lot of, we're also looking at barriers with professional boards dealing with behavioral health. We're specifically going to take a look at that. I mean, we had taken a look at, in general, all the professional boards here a few years ago. This one will be very narrow, having to do with that if there's impediments to providing those services. So there will certainly be, we're meeting either the 8th or 9th here to actually pick the members on the interim committees, and then they'll be announced. And so certainly if you get on the legislative website, you'll be able to see all the different studies that we'll be taking a look at.
This is Tim Mathern. I just want to encourage each person to take down this website, Legis, which is legis.nd.gov. And you can, after the meeting of the 9th that Representative Weisz talked about, there will be a posting of each and every interim study and the names of the chair and vice chair and the members of those committees. So the information will be there. You need to go to legis.nd.gov and it will all be available to you. One of the positive things about COVID has been we've gotten much better in terms of our data that we provide to citizens through our legislative council technology. So please, citizens, take care of of that and make sure we continue that in the future by using it.
Representative Weisz, I know you mentioned the merger of Health and Human Services, and I think most of us would agree that's I think that's a positive thing. Do you, is the monitoring of that going to be mostly through the governor's office? Will the legislature have routine and regular reports on that? And if there are concerns, how should they be addressed from those of us in rural or public health?
Thank you. Yes, they will be regular reports to the legislature. I guess my suggestion, if there's concerns among anybody in the healthcare community, etc., of where they see the direction might be going, they should reach out to the legislature, because when we come back in 2023, certainly if we feel we need to make some specific changes, we'll do that. But at least for now, we're leaving it up to the governor. There's funding available for them to hire consultants to start putting this process together. And certainly reach out to any of us, I guess, as legislators, if you see something, because we will certainly, I'll be communicating with the governor's office and the departments. So we'll, Senator Lee, etc. If we see something that's concerning, we'll raise those concerns with them. But in the end, if we have to, we'll look at legislation that will maybe correct something that we feel may have gone too far or whatever.
It's also important to note about the merger, and Representative Weisz gets a ton of the credit for this this bill having been well written and followed through on in a positive way. But the intent of the legislature, at least from our perspective, is that the people who work there are the ones who should be putting it together. That a bunch of legislators, no matter how smart we might all think we are, and we aren't all, the people who are doing the job, whose boots are on the ground, are the ones who should be figuring out how the folks who work in similar but not identical areas in each of those departments might best collaborate. After the pulling off of the environmental quality portion of the Department of Health, there are only a little over 200 employees remaining in the health department, all of whom are focused on health. And in the Department of Human Services, there's better than 2,200. So there's an administrative structure there that certainly it's possible over a period of time to plug in those administrative parts. From the other side, that doesn't mean that people are going to lose jobs. We've made that very clear in the bill too. But that we want the folks who are working in each division to be visiting with others doing work with the same constituency, whether it's professionals, providers, citizens of the state, to figure out how they could best do it. We've talked for a long time about no wrong door. We want people to be able to go in, and if that isn't the right office, they'll send them wherever it ought to be. We also want fewer doors, and we think there may be fewer doors if we do this right. And instead of being threatening to the two areas, public health and human services, this should be viewed as an opportunity for the folks who are doing the work to say, finally, I get a chance to say how I think we could do this better. And so I'm hoping that the people who are involved with this will view it that way and be positive participants in the process as it moves forward, because it will definitely take some time to do. And the legislature will look forward to seeing how things go.
Let's see, I think there's a question here. Amelia Metcalf, I'm not sure if she said, I'm not sure if I missed this. What was the decision and the ultimate outcome of SB 2030 and what it means for research and funding for higher ed? Thank you.
Bills by numbers, I know hardly any of them, but that one kind of rolls in. I think you're talking about the one that had the Planned Parenthood amendment that unfortunately was attached. In my opinion, unfortunate because it was not germane to the topic. The governor vetoed the portion of the bill that called for penalties. So that is gone. And the challenge grants are still available in the same way that they were before, which has been such a wonderful program for the universities. And as a sidebar, the the target there was NDSU. I think it's inappropriate for the legislature to meddle, but that's my personal opinion. But anyway, the NDSU's professor who has been using it for positive health information, and not certainly for abortions in any way, is not renewing that contract, and so the issue is moot, and that should have taken care of it. But anyway, the challenge grants are still very much in place, so that went away finally.
Thank you. We've got about 5 minutes left. My colleagues would string me up if I didn't thank you for continuing to fund Medicaid expansion. We really appreciate that, and I believe that makes a difference for a lot of people, a lot of lives in North Dakota. We certainly do appreciate that. So we don't run out of time. I want to personally take a moment to thank each and every one of you that are on the panel. Thank you for your time, your service to North Dakota, to your districts. We appreciate your interest in rural and public health, and appreciate you being on the panel. We love that you answer questions, and you're not like national politicians. You don't duck them. You hit them head on. So we really appreciate you taking on these questions head on. So there's another one I'll try to get one more question here, if I can get to it. I'm missing. There's something about family leave that somebody put in the chat box. I'm not seeing the question, but oh, here we go. Paid family leave, HB 1441. Why do you believe this bill failed? Did it become a study, and will it be selected to be a study? I understand that not all proposed studies get selected. So anyone want to take that one on?
Take that one. It failed. It was not selected as a study, and I'm trying to think of a good way to articulate this, and I'm just going to say it. I think that one of the reasons that it failed is that a large number of the people voting on the bill in the legislature have not personally been faced with issues related to taking family leave from their jobs. Perhaps they've had a spouse or a partner or parents who are able to provide child care, or who have been able to provide family care for an adult that has needed care, or have the luxury of working at a job where paid family leave is a benefit, which many of us don't have that luxury. And so I think personal experience or lack of personal experience with the need for paid family leave is a piece of that. And I don't see paid family leave going away, especially with COVID. We saw it become a huge issue for families and their economic survival, as well as the physical health of family members who were impacted by COVID. And so I would encourage people to reach out to their legislators and tell their story about why paid family leave is important, and how lack of it has impacted them, so we can keep policy related to paid family leave alive.
This is Tim Mathern. I would just add, encouraging the audience here to think creatively about programs that could be funded by the American Recovery Program, the new money that's coming from the federal government. This will be a lot of money on top of the CARES money. And I just encourage people to think more creatively than we have in the past. Generally, in the past, we've talked about roads and bridges and sort of shoring up government spending of our regular programming. But this idea of family leave, or there must be other things that people could be thinking about that could literally change the way we do things going forward. So I just encourage everybody to be creative and bring those ideas up through your departments, because we will have an extra over $1 billion to spend, and let's make it worthwhile for a long-term future. Thank you.
Thank you, legislative panel. Again, we are up the clock. Again, thank you for your time and your service. We certainly appreciate it. And we hope to see you in person maybe next year at the 2022 Dakota Conference. I know some of you are regulars, and we'd love to see you in person next year. So